Thanks very much, Matt. So let's see if this works for me this time. And there we go. Okay, so scoliosis and arthrogryposis is a very common finding. If you look at the literature, it's anywhere between 20 and 60 some percent. In my practice years ago, I went through and I looked to see how many patients I had and how many had scoliosis. It was about 22%. So anywhere from 1 out of 4, 1 out of 5 patients, at least in my practice, have it. And the highest rates seem to be with kids who have Escobar syndrome or those that have Friedman-Sheldon syndrome. So we'll talk a little bit more about that as we go along. Most of the curves happen before 5 years of age, and some are even present at birth. On the other hand, some curves don't come up until kids hit close to adolescence, and that's when we first start finding them. So scoliosis is any curve that you see a side-to-side curve. Usually what we say is that the curve's got to be over 10 degrees to really be called scoliosis. So if someone says your child's got an 8-degree curve, doesn't really hit the criteria for being named scoliosis, but it's certainly still something you want to keep an eye on. Kyphosis is this normal curve we all have in our upper back, whereas lordosis is the normal small of the back, but you can also have exaggerations, either too much kyphosis called hyperkyphosis, or the other side of it is not enough kyphosis, and that's hypokyphosis. And the same thing with the lordosis. So what are kind of our parameters for treating these, or why do we look to treat these? Well, the way we look at it is that if you have a curve, but you're done growing, your curve is less than 40 degrees, more than likely it's not going to progress any further in adulthood. So about 95% of them will not progress. Whereas if the curve is over 50 degrees, just about all the times that curve will progress. And between 40 and 50 is a gray zone where some may progress and some don't. They just have to keep a real close eye on them. The progression, though, in adulthood is slower than it is during childhood. But one of the points I make to parents is they're like, well, it's a 45-degree curve now. You've seen it progress. It's probably going to keep on progressing, but do we need to do anything about it? Certainly a whole lot easier having something done as a teenager than it is when you're 30 and the curve is really big now and starting to compress the lungs. Now, on the other side of things, curves under 20 or 25 degrees we usually observe to see if they're going to get bigger and then start to treat them at 20 or 25 degrees. And by and large, surgical indications, looking at these things we talked up here, surgical indications are for curves that are over 40 or 50 degrees, or we expect them to be at the end of growth. So what else is important? Why do we actually need to treat these curves? Is it just a cosmetic issue? Well, part of it has to do with how well people sit and stand. If you have a curve that really pushes you off to the side, what we call being unbalanced, you certainly want to do something about that to improve that alignment or to get somebody to sit more comfortably. Cosmetics play in there to a certain degree, but really what's most important is cardiopulmonary compromise. Cardio meaning heart, pulmonary meaning lungs, and having something that affects how they work. So pulmonary insufficiency, my favorite way to explain to parents is that the lungs get too squished, so you can't get good oxygen into the lungs or get the blood to where the oxygen is to carry to the rest of your body. So if you look at this person here, these lung fields are very condensed. They're not nice and inflated like they should be. They look like they're kind of squished together, particularly if you look at this one here, very narrow from side to side. And then when you have a long-standing issue with the lungs, and long-standing, we're talking decades, somebody in their 40s or so, with a really constricted rib cage or chest cavity, the heart's working so hard to push blood through the lungs that the heart starts getting pooped out. And that's called cor pulmonale. That means that the side of the heart, the right side of the heart that pushes blood into the lungs is just it's overworked and it starts to fail. And that becomes a real big issue. So typically that's what we see in curves that are over 80 or 90 degrees. So we get really worried about those. But if you actually do some sensitive testing, you can find that there are issues in how people are breathing, even if they don't notice it, at curves that are about 60 degrees or so. And what we're looking at here, so this is a CT scan through somebody's chest. And I can see that this has got quite a deformity too. Instead of being nice and oval like this, like it should be, it's kind of got this weird, almost like a pear shape when you look at it this way. And these are the lung fields here. And they, to me, look very small from side to side. Now, what's more important is what's happening here. So this is the whole lung over here on the patient's right side. But over here, it looks kind of funny. This area here looks a little whited in. And that is actually a non-functioning part of the lung. Because the lung is so distorted, we can't get air or blood to that part of the lung. And that part of the lung is essentially non-functional. So you already have the lung not functioning well because of its shape. And then even worse, that parts of the lung kind of shut down. So these are things that make treating these curves very serious, that we're not trying to just make a spine look good or have somebody sit nicely. We're actually trying to make sure that they have good lungs that work for them for a long time. So we talk about constriction of the lungs, that on the concave side of the lung, so this is the concave side over here, the height of the lung is decreased. And on the convex side of the curve, the lung is actually kind of pancaked. It's become quite narrow. All right, so when we talk about scoliosis, usually what we do is we talk about the age that we see the curve in. So you have the infantile curves. These are kiddos that they didn't have a curve at birth, but they got it by the time they were 3. A lot of times this is related to hypotonia. So particularly in arthrogryposis, we have some kiddos that when they're born, they're extremely, excuse the term, floppy. They don't have a lot of muscle tone to them. And particularly if we try to get those kids up sitting before they're ready to, they're going to kind of collapse on themselves, and that can kickstart a curve. And these curves can oftentimes progress relentlessly. The juvenile time span is between 3 and 10 years of age, or 3 until puberty. This is a rarer time usually to see a curve occur. Usually if we find one in the juvenile time span, it might have been one that was missed, an infantile, or somebody's kind of going through their adolescence a little bit on the early side. But occasionally we do see ones that just pop up during the juvenile time. And then you have the adolescent ones. These are ones that happen around puberty. Now, this is when we typically see curves in typically developed kids, is 80% of those curves will happen during adolescence. And so it goes to reason that in arthrogryposis, we're also going to find a number of those curves that happen during adolescence for the same reasons that we still understand. Then there's a group of curves called congenital curves. These are kids who are born with a curve, but they're born with a curve because the vertebrae aren't built right. The vertebrae have some structural abnormality to them, and that kind of causes a curve. And that's different from what we've gone to calling the prenatal curves. These are kids who are born with a curve because they never moved intrauterally. So they're in their mom's womb, and they're kind of off to the side, whereas a typical child is kind of like swimming around, and they're able to unbend themselves from time to time. These kiddos never moved, and so they're born with a curve to start off with. Very much like this kiddo over here. So this is a curve that he had when he was born. And it kind of has a little bit of a waxing, waning course. Here he is up on his knees, 4 years of age, not a bad curve, doesn't look a whole lot different at 8. And then it started to progress. So he hits adolescence. Again, that's that magic time period that we don't like too much. And now the curve starts to progress, and he ended up having a fusion. Here's another kind of congenital curve. And this is not so much a scoliosis as it is a hyperlordosis, but you can kind of, again, get the idea of how this child was positioned inside their mother. And they also have cervical hyperextension, that the neck is really cranked backwards. This is one of those things where you're hoping that the obstetrician figured this out way ahead of time, realized that the baby has to be carefully delivered through a cesarean section, that a regular delivery would not be a good idea. And this is what this child looked like here. And so we try to come up with some kind of a system to slowly stretch them out and get them straighter. So let's talk about the infantile curves a little bit. So here's a 13-month-old, and at 17 months, that curve is getting somewhat bigger, and it just keeps on kind of changing over time. And so these are kind of the difficult curves. That child at the bottom, you saw the child had Escobar syndrome. Here's a juvenile. So at 7 years of age, she had an 18-degree curve. And again, we started bracing a year later because it got over 25 degrees. And we're able to kind of keep it in check with the brace. Here she is at 1749 degrees. Again, a big worry for me. I'm going to keep on watching this child as long as I can. And if it makes a meaningful change, we're going to turn to her and say, even though you've made it to your later teens or maybe your early 20s, we still have to do something to stop this from being an issue so that at 40 you're still sitting comfortably. What are our treatment options? Well, there's not a whole lot in the literature about arthrogrypotic spines. There's more and more coming in there, so we have more things to kind of look at, but it's still, they're small series. They're not a whole lot. You kind of pull everything together and get some ideas. So it's difficult to draw conclusions, and a lot of what I'm going to be talking about here is not only what's in the literature, but also my own experience. And in another talk I give, I give a Will Rogers line, which is that good judgment comes from experience, and oftentimes the experience comes from bad judgment. So it gives you an idea that we're learning. But there's many things we can do to treat children. Physical therapy, spine casting, bracing, and then different kinds of surgery. So we're going to go through all these piece by piece. In physical therapy, very early on, we want to work on trunk strengthening, especially what we call asymmetric exercise. If you get a child to kind of pull from side to side and to get those little muscles on the bottom strengthened up in their spine. My favorite way, if they're already able to do sitting, is sit them on an exercise ball and kind of bounce them to the side and bounce them to the other side while you're playing with them and trying to see if you can get them to strengthen up that way. I also like a lot of tummy time for kiddos who are not yet to sitting, if they can tolerate that, because oftentimes they'll try to pull their head up to see what's going on, and they strengthen their muscles that way. Sensory integration, trying to get them used to where their body is in space so that they get the idea of how to straighten themselves up. There's our tummy time. Now, in the low-toned babies, I caution parents not to try to get them up sitting too soon. All of us who are parents, we love to take our kiddos when they were like 8, 6, 9 months old, or even younger than that, try to get them sitting up for us because it's so fun to make face-to-face contact. But if you got a very low-toned child, doesn't have a lot of strength in their core, they're just going to collapse. And I've had it happen plenty of times. Parents go, look at this, I'm so proud my child's sitting. And they got their arms on their knees, they're kind of holding themselves up, and they're still completely crunched over. And if you take the arms down, they will completely collapse. We don't like that because we're worried that that is going to kickstart a curve. So I recommend when you have a low-tone child, you try to always sit them in something of a seat that's got a back to it, that's canted back a little bit, just so that until they're strong enough to pull themselves upright, they can always rest, they can look out the world, but there's something stopping them from kind of collapsing down. Now, what do we do if we have a young child who's got a significant curve? My first go-to is spine casting. So you can see, in fact, in this child's case, got a trach, it's a fairly involved child, trach and a G-tube. So the whole idea of spine casting, I like to talk about this as being an old technique that was reborn, because back in the ages before we had spine implants for spine fusions, this is what they used to do. They used to cast people, and then they actually do surgery through the cast. But then a woman by the name of Min Mehta from the United Kingdom came up with the idea of casting little kids, babies and little kids, and putting a cast on every so many months, trying to straighten out the back a little bit by little bit, and found that really worked. So I've always said, this is something I want to start before 3 years of age, but I've had some kids who have actually started a little bit earlier because we didn't know what to do with them. We wanted to do something. You do this under anesthesia. And the schedule is, if they're under 2 years of age, we change it every 2 months. Between 2 and 3 years of age, we change it every 3 months. And then over 3 months of age is every 4 months, so we change the cast. It is a big commitment for the families. What always impresses me about this is how well the families adapt. So I've had a number of kids that when they're over 5 and I start talking about, hey, we can start doing surgery, that I've had parents go, what's the rush? We're doing good. Let's keep going with the cast. So it's not an easy way to go, but it's something that families seem to tolerate. So let's talk a little bit better. One of the things we're trying to do with that is not only correct the side-to-side curve, but the thing to understand about curves is that they got a rotational component to them. So if my forearms are ribs and my thumbs, my fists are the spine, and so this is front and this is back, what happens with the curve is that the spine column rotates. And when it rotates, it kicks some ribs backwards and it kicks the other side of the chest forwards. And that's why when you look at somebody's scoliosis and you have them bend over, you see they have an asymmetry. And that's kind of what we're showing here, how the spine is rotating. It's kicking some ribs up, like you see over here, kicking some ribs some backwards and some forwards. So what we try to do is on this special table here, where we have access to the whole baby, is try to unrotate the spine at the same time, kind of push it from side to side. So something like this, or I've got this is what our table looks like. This is done under general anesthesia. I do have a colleague, a friend who's experimenting with doing this with a child awake. I'm not brave enough to do that yet. They have the child playing on iPads and things like that, because this is what what it looks like. So here we have the child. So this is open here. They're kind of on a bar here and a bar there. They've got this, what we call head halter traction, kind of traction that comes behind the neck and underneath the chin. And we've got a couple of straps around the pelvis here. So we're kind of pulling them out to length. And then we wrap them with plaster and we mold them, put a nice layer of fiberglass over it, do our cutouts, and then wrap it up to make it look good. And it's always funny when you put together a talk and then you look at it 5 minutes before and you're like, why did I put all this stuff in here? There's a lot of scientific study kind of stuff, so I'm going to kind of skip through or kind of make it a little bit easier because a lot of the stuff is a little too detailed. But anyway, so we looked at the kiddos that we had done. We have 14 kids with arthrogryposis that we had done casting for, and we just measured their curves before and after casting, and looked at a bunch of other measures. And some of the stuff we looked at, so we have this thing called the rib vertebral angle difference, and that gives us an idea of how much asymmetry there is, and we'll see that on some of the x-rays, or how much the spine is rotated, looking here at what's called the Nash-Moe rotation, or the really important one, what's the asymmetry of the lung spaces. So your lung spaces, if you go from the diaphragm to your upper rib, it should be symmetrical. You should have the same height on both sides. So if you have a lot of asymmetry, that gives you a measure of how much deformity you have in your chest. So having said that, if you look here, space available for lung, you can see that we have some asymmetry here. So in this case, it is about one side is 80% of the other. And if we look here, rib vertebral angle difference, we're looking at the shape of the ribs here and seeing how different they are aligned. And again, it gives us a measure. This should be about 0 for most of us. In this person's case, it was actually 80 degrees of difference. Goodness, it goes on. Okay. So what we were looking for in our patients is how many did we cure? That means that we went through casting. At the end of casting, got the curve small enough that we could then transition them into a brace and a year later get them out of the brace. How many we just got down into a bracing category? We braced them long enough that they're older, or sorry, we cast them long enough that they're older. We just put them into a brace, and now we're kind of expectantly treating that at some point in time we'll have to do surgery, but at least it's not imminent. And then we have the control group, those that when we went into casting, we knew they would need surgery at some point, and we're just trying to nurse them along until they're old enough to get the surgery. So you have a curve like this, you put in a cast, you see it looks straighter. This is what the cast looks like. And here, the average that we started casting was at 28 months, but as young as 10 months, as old as almost 5 years of age. Number of casts on average was about 9 casts, but some of the kiddos that we were trying to control was up to 20 casts because we were casting for several years. And the average time of cast was almost 3 years, but as short as just a little bit over a year, and as long as more than 5 years there. 6 years. Now here's the part that you look at and you go, what'd you do? Start with the 52-degree curve, and at the end it was only 51 degrees. That didn't make a whole lot of difference. The way that I make myself feel better about this is saying, yeah, but there's a lot of years in between that we were keeping this curve in control. If we hadn't been able to do anything else besides maybe bracing, the curve would have gotten a lot bigger. Little bit, when we look at kyphosis, we had a little bit of change in kyphosis, but nothing really meaningful. So here's a young kiddo, 28 months old, Sheldon Hall syndrome, casting him out for a little bit more than a year. And now we got the curve from 40 down to 22. He is my only cured curve. Here he is 2 years later. It's still 18 degrees. Now I can tell you he is now a young teenager, and we're back in braces. But we're keeping in control. And he had several years without braces, whereas usually when you look at a kid who's not even 2.5 years old with a 40-degree curve, you'd expect that they'd be going to surgery as a young child. So we're able to kind of push that far into the future. Now here's a brace kiddo, start with the 64-degree curve. That's a very big curve for a 2.5-year-old. At the end of casting, got down to 37 degrees and have been able to maintain it, at least at 1 year later, been able to maintain it with bracing. So again, this would have been a surgical curve, and we were able to kind of postpone that maybe even better than that. We'll just have to see how that story plays out. And here's a controlled curve. So this child started off with an 84-degree curve. That's a very big curve. And they're only just over 2 years of age. Here we get them 2 years older, and we've been able to keep the curve about the same size. So not a huge win, but at least we got them to grow a little bit better. And then we ended up going to what's called a magic rod here. So one of the questions you might have is, well, why didn't we do this much sooner? Why didn't we just escape this whole casting thing? Well, the important thing to understand, we'll talk about that more when we get to these expandable implants, is that the expandable implants have about a 5-year lifespan, that once you put them in, the child starts to stiffen up. And so some of them, you can lengthen them for 5 years. You might be able to lengthen them longer than that. Some of them, you can't even lengthen the whole 5 years. So if you put it in at 5 years of age, you get into 10, well, that's an okay age to fuse somebody. You got a pretty good sized chest at that point. But if you put it in at 3, you only get them to 8. For boys, it's only half their growth. And so they may have a very small chest. And that's the same thing with, well, goodness, why not just fuse this child at this age here? Same issue. You're going to have a child who's now turns into an adult with a chest the size of a 5-year-old, and that's not enough room for the lungs. So a lot of this is always thinking about what are the lungs going to look like when we're done growing. Here's another child, controlled curve, 71-degree to start off with. We did a few casts. We were able to get it down sizably within a cast, and then the curve took off with us over here. So we had to put in the magic rods and get them more straightened out. All right, so a whole lot of, I'm just going to skip through this because it summarizes nicely here. So if we look at the child with the cured curve, went from something to 40 to something to singles. The braced one, we just maintained the curve pretty much. And the controlled one, it crept up on us slowly, but we were able to kind of slow down how fast it was increasing over the years so we can get them older to do surgery. Same here, that one cured one, we got that asymmetry to get better. The braced one, we got a little bit better. That controlled one, no, we didn't at all. Rotation, same thing, 2 to 0, 1 to 0. And then here's probably the most important part for me. Here, this is the space available for lung, that lung asymmetry. It wasn't bad to start off with. It didn't change a whole lot. Here, it was moderate, and we kept it the same. Here, this was not a good place to be at 0.76. We improved it a little bit to 0.86. And the other thing is that we allowed the child to grow a fair amount. So about 50 millimeters, that's about 2 inches of growth that we got on them during the stage that we were casting them. So that's important to get them a little bit taller. Same over here. Here a bit less because unfortunately as the curve gets bigger, you start losing some height on that. So in some ways, the curve behavior kind of defines what our goals are. If we're casting it and this curve is coming down nicely, then we say, we got the curve under 20, maybe got it under 10. That's a cured curve. I hope to put this child in the brace for a year and then get him out of the brace. If the curve comes down somewhat, but it doesn't come down to under 20, then all right, I'm just going to go at some point in time, we're going to choose a point that we transition to a brace and we'll keep on treating with a brace, looking to figure out when do we have to do something more for it. And then you have the ones that are the bigger ones where from the start we know we're going to have to do something for them surgically, and all we're trying to do is get them to at least 5 years of age before we go the surgical route. What about bracing? Well, bracing is for curves that are over 20 to 25 degrees, kind of the same as with casting, but it's for kiddos who are too old for a cast, or there's another reason why we can't do a cast. Because the thing about bracing, we can prevent or slow a curve progression, but you can't really make a curve smaller, and casting can do that. Now it brings up the whole question, what does casting do and bracing doesn't? Is it because you can take a brace off or because the cast is more rigid? Great discussion over a beer. But anyway, so this is kind of what a brace looks like. This child's a little bit more the hypotonic sort. You can kind of make out she's got this curve here. We put her in this. It's almost like squeezing the toothpaste in the toothpaste tube, get her kind of straightened out like that. And kind of what her curve looks like in the brace. So here's one story. This child is 2.5 years old, 40-degree curve. And here we got the curve down about 10 degrees in the brace. Not great, but okay. And then slowly over time, the curve got a little bit bigger so that when she was 6 years of age, we had a 55-degree curve. I would probably keep on bracing at this point anyway, try to get a little bit older before we did anything. Here's a 7-year-old with Escobar syndrome, 53-degree curve. And we were able to get them 4 years bigger before we said, okay, we have to do something for that. So that's pretty good because now at 11 years of age, we can just do a final fusion, a one-stop procedure, and we've got them in a good place. So what about surgical options? Well, fusion is very attractive because it's you do one thing and you're done. But like we talked about, if you do that in an infant, you're going to end up with an adult who's got an infant-sized chest, and that's not good for supporting pulmonary function, for supporting what the lungs have to do for you. And you also make the chest fairly stiff if you do that. Now, expandable implants have been around for a while. The really exciting ones are the ones that you can expand without having to go to the operating room. But these come in different varieties. There's the vertical expandable prosthetic titanium rib. There's growing rods, and there's magic rods. And like I said, about a 5-year effective treatment time before things get too stiff. The other thing is that some of the kiddos who are very hypotonic, and this doesn't really display very well, but the ribs, instead of the ribs going in this kind of a horizontal direction, these are going almost in a vertical direction. And sometimes what you find is you're making the spine longer, but those ribs are just going down like this. We call that the collapsed parasol. And that it's a hard one to figure out what to do because you're gaining height, but you're not gaining lung room. And there's a bunch of different complex things people can talk about, but it's an unanswered question of what you can really do. So this is kind of the first iteration of expandable implants. And what you'd have here is a rod, maybe on one side, maybe on both sides, coming down and connecting with the rods coming from the bottom up, and then a little connector in between. And what we do is every 6 months, we go back to the operating room, loosen things up, distract them out a little bit, and then tighten the connector again. And that was a very efficient way to do it, but twice a year you're going to the operating room. And it's usually an outpatient procedure, but still, you're making incisions. Incisions can get infected. There could be all kinds of other complications with this. This is the prosthetic titanium rib, or it's the expandable titanium rib. And this was a very neat thing when this came out, that it's a manually distractible implant, but it was made to attach to the ribs up top here. And this was actually created for kids who were born with a very specific crippling chest issue. And when it came out, it really saved a lot of lives. Then we started using it for different things too. Not used too much anymore. Neither one of these really are, because we've really gone more to this, which is the magic rods. Magic stands for magnetic activated, blah, 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 blah. Essentially rods that have a little magnet up here and down here. And that magnet, if you put an external magnet on them, an external electric magnet that rotates, it rotates the little magnet inside the rod here and can make this telescopic rod elongate. So that works nicely. The problem is that these are of limited strength. So I can do a whole lot more pushing on the spine here or here because I'm doing the work versus these here. So we've had, unfortunately, a number of kiddos where after a certain point in time, it just can't push hard enough to keep expanding it. And so that's one of the problems with these. So there's not yet a perfect solution. This has been nice because we can stay out of the operating room for a fair amount. But sometimes we have to come back a little bit unexpectedly because things are not elongating. Maybe the rod's a problem. And we just kind of take out the rod and start again. So this is what that external magnet looks like. Oh, there we go. Magnetic expansion control rod. There we go. So use the external magnet. We lengthen, instead of every 6 months in the operating room, we do every 3 months in clinic. It's about a 5-minute issue. It doesn't really bother the kids very much. And then we just get a new x-ray. So 5-year-old, 103-degree curve. And we had casted him. He was in the surgical group. Put the magic rod in. And usually you get a really nice correction from the start just because you're putting this rod in and kind of using that as an internal splint or an internal brace to lengthen them out. And then gradually over time, you keep on trying to lengthen them out. So here, 2 years after we put the rods in, you can see how much we've lengthened it. This clear spot on the rod is the area that's gotten lengthened right there. And what I'm also showing those arrows there is how he was trached up here, and then he was doing well enough we could take the trach out. So we looked at our kiddos who had the magic rods, and we had 7 kids, so a very small study, again, like most of these arthrogryposis studies are. And we looked at the same things we looked at with that other study we were talking about. And the one thing that we found is that we were able to get a fair amount of lengthening on them in terms of their spine height. We also looked at how much the rod would lengthen by measuring this area here. So what we find, so the average age that we put these in was 7.5 years of age, as young as 4 years, and even as old as 11.5 years. And we were following them for a little bit more than 2 years. And we expanded about a little bit more than an inch. So 25 millimeters is an inch. So we only were able to expand them about an inch with this, which doesn't seem like a whole lot. Now, it did get an average preoperative curve of 82 degrees down to 53 degrees, which is pretty good. And you see how these curves are as big as 106 degrees down into the 70s. We did have a little issue with increasing kyphosis. That when you look at the top of the back from the side, that they got a little bit more curved over this way. And we'll talk about that in a second here. This kind of summarizes the same things. I'm not going to spend a lot of time on that, but we did get the space available for lung a little bit better. And we got them a bit taller. So got them from 260 millimeters to 303. So about 40 millimeters taller. Not quite. It's about 1.5 inches, a little bit more than that. So here's a 5.5-year-old. It's got an 80-degree scoliosis. There's his vertebrae. We could only fit 1 rod in because on the other side he was too curved to get another rod into him. We were able to lengthen that out, and that worked pretty good. We were able to keep the curve kind of in check down to 55 degrees, but then this is the part that's troubling, is he had some increased kyphosis at the top, and you put the rod in and that kyphosis gets worse. And the thought is that you're expanding the back, but the front doesn't want to come along for the ride. And so as the back's getting bigger, they're just kind of curving over more. So again, every time we come up with something new, we create more questions for ourselves or more things we have to solve later on. So in a lot of cases, like that last case we were talking about, we have to sometimes just put a rod in on one side. And that's kind of such as this child here, again, another 81-degree curve. And put just a single rod in to kind of lengthen that up because we couldn't find a place to put a rod on the other side. But it does help. If you take a look, again, this is not a great amount of rib space from side to side, but much better than it was over there 2 years earlier. So it does help with that. Now, one of the things we do find is that, like we talked about, these have a finite lifespan, that over a certain period of time, the spine starts to tighten up on its own. And that's what we'll find. So this young lady here, 11.5 years old, we put the rods in, we try to lengthen her out. We only got about 16 millimeters, so we got a fair amount of correction from 81 degrees to 32 degrees. But what we ended up doing at this point here, we couldn't lengthen her out anymore. We figured everything was fused up. If you take a really close look at the x-rays, you start seeing that she's actually started to fuse some of her vertebrae together. So we said, well, instead of doing a formal fusion, opening up her whole spine, looking at it, roughing it up, trying to get it fused together, we're just going to accept what she's done for us. And then what we did as a final operation is just open up our incision here, open up our incision there, took these rods out and put some solid rods back in, same screws. Was about a 2-hour operation, not a whole lot of blood loss, and she's on the hospital for a short period of time and could go home. So instead of going in and doing the whole fusion, we just did this quick replacement. So essentially, kind of the same stuff we talked about. How are we doing on time, by the way? Ooh, okay. Want to leave some time for questions. But yeah, so this is at the bottom here. This is my favorite thing to do, is to graduate the kids. Take the rods they have in, take those out, put solid rods in their place, and not do anything more for surgery if I think they've already fused themselves. What about an actual fusion? I know I only got 10 minutes, I know. What about a real fusion? This is if you have somebody who is unbalanced, we got to balance them up better. We have a big curve, we'll make the curve smaller so we get the chest more symmetrical. And we also, one of the important things, particularly for walking, children, we want to get them to have a good profile. One of the things that people oftentimes miss, that we as orthopedists miss for several decades when we started doing the fusions, is the front, the view from the front. You can make that look spectacular, but if you've got the view from the side off, you are creating somebody who's going to have a lot of problems when they get to a certain age. We all lose some lordosis, some of the curve in the small of our back over time. And if you have a very straight fusion where, boy, you look like a great soldier, when you start losing that lordosis, you start leaning forward and having a lot of back pain. That's when you sometimes will see people walking with their knees bent when they've had a fusion like that. So this is one of those things that we really try to make sure that we get that sagittal profile correct. So how do you do this? You hold the spine in position with a combination of rods on each side and hooks, wires, and screws to hold that to the spine. So here's a 16-year-old. She's got amyoplasia. She's also got some pelvic obliquity. That means that when she's sitting, she's only sitting on one tush because she's very curved. She wasn't a walker. So 96-degree curve. And this is what her fusion looks like. In this case, we went all the way down to the pelvis. You don't always have to. A lot of the curves, you can stop someplace in the middle of the lower back, in the middle of the lumbar spine. But here you see all these different screws are going into the spine. They're on either side of the spinal cord. And you got the rods there to hold everything in place. And what you're doing once you get the spine straightened out like that is that you're roughing up all the vertebrae. So the vertebrae think that they've been injured and they try to heal themselves. And when they heal themselves, they heal one vertebrae to the next, to the next, to the next in the area that you have the rods. And so if we came back a year later, we would probably have a solid bone back there. That solid bone won't bend, and we could take out all our metal if we wanted to. There's not a good reason to take out all that metal. It's a very intensive, bloody procedure to take out that metal. It's best just to leave it in place. And by the way, no, it doesn't get colder in cold weather or heat up in hot weather or get any kind of radio signal. But so this is what we're talking about. So she's only sitting, so I want to have the right amount of curve in her lower back so she can sit comfortably. But yeah, much is unknown. We still have to figure out more on how to treat kiddos with arthrogryposis better so that we can make sure that we are fusing the right amount of levels. We try to fuse just the right amount so that you leave them with some flexibility. If you have a walking person, we don't want to go all the way down to the pelvis. We want to stay out of the lower back as much as possible, but you don't want to fuse so little that then they run the risk of getting a curve as they age. So it's a little bit of trying to figure out how to do things right. Some of you have gone to some of Naomi's, Dr. Han Ulios talks. You did a couple of research talks, one yesterday, one today. I've been lucky to be a part of some of these studies that we've been doing. What we tried to do is figure out what genes are related to scoliosis. This is one of those huge database kind of studies where you get a lot of data out of it. I'm not sure what it's going to lead to, but hopefully in the future somebody can figure it out. But we found a total of 227 genes that are both related to arthrogryposis and scoliosis. Tantalizing information, not sure what to make of it. And hopefully in the future we will figure that out better. We also did a specific study looking at kids with Escobar syndrome and trying to figure out more what goes on with their curves. Escobar is caused by two different forms. It could be caused by the CHRNG gene, or which has something to do with the acetylcholine receptor, or it can be related to the MYH3 gene, which has something to do with the myosin heavy chain. This one, you need both parents to give you a copy of the gene. This one, you only need one parent, excuse me. And what we found is that very much like other curves, you can have curves that are less than 25 degrees at any age. We'll call that a mild curve. You can have the moderate curves that are between 25 and 50 degrees at any age. So that's kind of like this child here. The severe curves that are over 50 degrees, but after 4 years of age. And then we identified, so here's a child, this one she was up until a young teenager, not a whole lot of curve. Actually, she was pre-teenage years, but then suddenly got a curve and it kind of took off on her. But then we came up with what we call the malignant curves. These are ones that are over 50 degrees before 4 years of age. And these are really, really scary because the curves get so big that they start to deform the chest quickly. And we worry a lot about how the respiratory function is going to be. So here's a particular case like that. Unfortunately, it doesn't project very well, but this is a very, very big curve in a child at just at 34 months of age. There had a 68-degree curve, and it just kept on progressing. So at 5 years of age, they underwent this surgery here with some expandable rods down there. And so they were too small to have the magic rods. So these are actually just another form of manually expandable rods. So we have to go to the operating room to get that lengthened. So scoliosis and Escobar syndrome are very common. And the kiddos who have this myosin heavy chain type of Escobar syndrome are the ones that we really want to keep a close eye on because they seem to have a higher prevalence of the malignant curves. But even in families that had more than one child with Escobar syndrome, we find very different ways that the curves behave. We had a couple of sibling pairs where one kiddo did well until they were in adolescence. The other kiddo had a huge curve before 5 years of age. So very different how things can work. And again, beware of the malignant curve. So it's something for my colleagues to know about, and for any parents who has a child with Escobar syndrome to just get frequent x-rays to be really right on top of the curves early on. So thank you very much. There we go.